Well, we were living up in Pennsylvania. A friend of ours lives here in Virginia. They asked us to come down, so we gave everything up in Pennsylvania to come live in Virginia. A month of living with them, they threw us out, and we've come to the Valley Mission, and we enjoyed every minute of the stay here.
That's what happened. We had nowhere to go, and thank God for the mission.
Well, during the pregnancy, we were okay. We had a place, and then once I had the baby, things got, I couldn't go back to work because of health issues. Jonathan, with his leg, he wasn't able to work, and so we were still, at our place, but we had trouble with our landlord. He kept coming in drinking in the evenings, and he would just let himself into our house, and he carried on. So we had to call the police and have him removed, and then from there we had to leave. We left because it was no point in trying to stay there and fight with him. And so then we went with his family for a little while, and we came here. We thought it was best to try to get a fresh start and try to go from there.
Had to pack up my things and leave my home and put it in storage and everything. And so And so because of that, the house, I had to get rid of the house, and so I wasn't able to get housing like I wanted to, and so I ended up on the streets. I guess I would say the last place that I was living at was living in my storage unit.
Just being here helped us out a lot. It was better than being on the streets.
Whenever I needed someone, they were there. They were there. 24/7. Not 8 to 4, not 9 to 5. They were there 24/7.
It's good for me because, you feel, it kind of makes you depressed when you have to come to a homeless shelter, especially with having kids. You feel like you failed them in a way. And so it was good for me to come in just because I know that there's other families that are going through the same thing as what I am. And you don't really need to feel ashamed or bad. It's just you need a hand up to get back to the way things should.
The mission has helped me a lot by having a place to lay my head. I was able to get a shower every day, and I'm able to eat 3 meals a day.
And then working with people, you learn a lot about yourself. You learn about your strengths and your weaknesses. See, it's one God, we're all God's children, we're all kin, regardless of where we come from.
Just so, because there's always people that are less fortunate, just like us being here, there's always someone though that's worse off. There's someone else that's out there that needs more help than what you do. And so it's it would help provide stuff like the toys for the kids, or food, just if you need things like shampoo and stuff like that, you can ask for it, washing powders. So you're not struggling, because there's things like that you can't really afford to put your money into at this time. You need to be focusing on other things, so it helps if you don't have to worry about the small things and you can focus on the big things. Yeah.
It's just not just giving me a place to lay my head. It is a place where there's a lot of good people.
An email from a volunteer from a church explaining that you had an opening for an after-school coordinator. And I just retired from Augusta County Schools after 37 years. And I thought that was something that maybe I could do and was interested in. It serves anybody in elementary, middle, and high school, kindergarten up to 12th grade. It's a great place to work. It's a fun place to come to every day, and the students are very appreciative as well. Probably the hardest part is it is life with a revolving door, and that often the students leave, and there is no closure for us anyway to say goodbye to them and to wish them well. And we just come back the next day and they're gone. And so you just have to trust that life will be good for them, that they've made forward progress.
Well, Michelle had asked me if I would come in and help out. Lana that was here was leaving, and that you all needed some help in the kitchen, so I started volunteering. In order for people to progress themselves in life, they have to feel good about themselves, and one of the ways that people can feel good about themselves is if they're fed well. I actually like it here. I really do. At first, when I started working here, I was a little nervous because I wasn't sure what the expectations would be, wasn't familiar with the kitchen, wasn't sure if I would be able to connect with the residents. And then after being here for a couple of weeks, I actually feel like I needed this more than you all needed me.
And I just want to thank all the people that help run the mission for what they have done. It's a great place to be when you are in need of help.
But the mission is a blessing to everybody. And I want them to know that not only is it a blessing to us, but we should show our worthiness of it, because each and every day is not promised. I believe in doing the best that I can while I can.
It's a positive place. I don't, there's, some people are down about it, but it is what you make it. And so, I enjoy it just because I'm able to sit down and talk with other people and find out what their story is and how that relates to you, and you can kind of help people. It's like you're serving people even though you're not really in a position to serve, if that makes sense.
One day at a time.
So as you can see in between each of our sessions, we're doing some vignettes from local community partners. You'll see a series of those throughout the day. So far, we built a foundation this morning so far where we've had kind of a general understanding around housing and some of the challenges around talking around housing and some data to help support that, and then data specifically for this region with Mel's presentation. And now we're going to start to dive in a little bit to specific sectors and specific areas. So it is my pleasure to introduce this next session, Homelessness Makes Us Sick. We've got three persons participating in this. Lydia Campbell is the Community-Based Services Manager with the Valley Community Services Board. And throughout her career, she's found a passion in homeless services and special needs housing. Dr. Clint Merritt is an internal medicine physician and currently serves as Vice President and Chief Clinical Officer for Population Health at Augusta Health. And then we also have Sherry Meadows, a community partner who's volunteered to share her lived expertise as part of this conversation. So please join me in welcoming them to the stage.
Good morning. I feel really fortunate to have so many community leaders and partners here, all for the same conversation around how do we help with housing locally. Our connection, our point for this talk is to draw the connections between housing and health. And we're going to do that by sharing a few local stories of community members who've experienced homelessness, share some of the local data that we see around health for those who are housing insecure, and then share some of the lessons we're learning as a healthcare system that deal with bias and how we approach this work at the intersection of housing and health. So that's our format. I'm really lucky with the experts I have here to help me, as you're going to see as we go through this. So knowing our time is short, I'm going to start by asking Lydia to tell us about a first neighbor.
Yeah, so neighbor one moved in spring of 2019 and passed away in the summer of 2022 at the age of 48. This individual lived with serious mental illness, substance use disorder, congestive heart failure, and kidney failure. They did have prior involvement with the criminal justice system. They only received income, the very little amount that SSI provides, in the last 3 to 4 months after years of applying and being denied. This individual was able to pass in their own home with hospice care. They had very limited family supports. They were a member of the LGBTQ community. And there weren't any family supports to make the funeral arrangements, so our staff took care of that before she passed.
So when I hear about neighbor number one, a few things come to mind. One is the young age of this individual at passing away at age 48. And the list of health problems that you see up there with kidney failure, heart failure, and substance use disorder addiction, these are really challenging things to manage when you've got lots of resources and a great support system. I think is a good lead off to this intersection of housing and health. You know, Augusta Health, for the first time in several decades, we changed our mission statement this year and evolved it to this mission statement. We're going to strengthen the health and well-being of all people in our communities. Sounds like a typical mission statement. For us, it meant several new things that you might not realize. This was a mission statement more leaning into the to inclusivity and all, to the idea that part of our work is understanding who's not doing well from a health standpoint and leaning into that. It's also a mission statement that was intentional about diversity, in that the Stanton, Augusta, Waynesboro area and our broader service areas, Augusta Health, is actually many communities, many neighborhoods that have very unique needs and very unique strengths when you work with them. And our mission changed from providing access to excellent care, which has been our mission for a long time, to actually making the community healthier. Let's lean in and say our goal is actually a healthier community. So it's forcing us to ask better questions. And I think COVID pandemic really helped us in this regard. Who in the community is not doing well? How do we understand those disparities? What are the local drivers? And most importantly, who are our community partners who help us lean into this? And this is an example of some of the mapping we use. These are folks that came to us last year for help at Augusta Health who said they were food insecure, who also have diabetes. There's a strong connection between food insecurity and diabetes, and they live in Waynesboro. And this kind of mapping helps us figure out programming to work on food insecurity and diabetes together. When we are committed to a general goal of making the community more healthy, we really are expanding the work we do as a health system. The fact that a health system's at a housing conference, you know, that's forward movement for sure. And one way to think about this is if I ask the question, I may live to 65 years old, let's say, and my friend Lydia here is going to live to 85. What determines that Lydia's got 20 more years of life than I do? And there's a number of ways we map this. This chart tries to get at that mapping. One of the things we're learning in healthcare is about 20% of my health status is related to clinical care. That's things that we do all day long. Treat diabetes, treat depression, find cancers and treat those. About 5% of my care is genes. 20% is that I don't exercise enough and my diet isn't very good. Those are my behaviors. But there's a whole lot of my health status that is driven by my lived life, where I live, and the conditions of my life. Those are those social drivers of health that we talk about. We've been working on how do we understand the social drivers of health better. And one of the tools we're using is called an Area Deprivation Index score. This jigsaw puzzle is the map of our region, Stanton, Augusta, Waynesboro. It extends to Albemarle County and north and south to Rockingham and Rockbridge. And each jigsaw puzzle is a census tract in our area, around 1,500 people. I like mapping in this way because it's getting kind of close to neighborhood level work. And the Area Deprivation Index takes 17 measures of wealth, such as income level, education level, the housing, and combines those into a composite score for each neighborhood. And then they rank that and color code it so that A 10, deep blue, a 1, deep blue, highest level of wealth in our area, that's Albemarle County. Go out to West Augusta County, the Craigsville area, you also have the highest level of deprivation or highest levels of poverty. And we've been looking at this data to ask, can this tell us how to focus our resources better as a community, as a health system? And the way we've done that is we've taken 200,000 people who've come to Augusta Health over the past 5 years. We have their address, we map their lat-long score, and we get their area deprivation index score from where they live. And then we ask, does your neighborhood predict that you don't see primary care in the past 2 years? This is Waynesboro. This is Waynesboro. It's area deprivation map. And we find this very strongly predicts the neighborhood you live in, the lack of seeing primary care in the past 2 years. Well, when we plan our mobile clinic, we're going to the deep red areas then. We're using the mapping to guide our services. It also predicts fairly well who's going to come to us for a mental health crisis in the ER. Neighborhood you live in predicting mental health crisis. That's hugely helpful because we have some great partners, some of whom are in this room right now, who are asking, hey, can we figure out how to get to the people that aren't getting to us better? And we use this mapping to figure that out. This one surprises us a little bit. If you come to the hospital for an admission, for a stroke or a heart attack, a pneumonia, does your neighborhood predict the likelihood of passing away in the hospital? And it turns out it does. This is local data, our neighborhood, our hospital. And how do we understand that? Well, if you get admitted for a stroke or you get admitted for a pneumonia, you bring your lived risk with you. You bring decades of your life with you into the hospital. And it isn't just your age that predicts mortality. It isn't just having diabetes and kidney failure and all the chronic health problems. It turns out it's your lived experience. And we unpack mortality all the time in the hospital. We're gaining in the ability to understand social risk a little better. So where does this lead? Oh, this is us using our map for our mobile clinic. As you'll see, the mobile clinic locations that we're going this year currently are a lot of the neighborhoods that are red on the area deprivation index map. So going to homelessness. Last summer, we did a community health needs assessment. We surveyed the community on a number of things that we believe impact health, including homelessness. And a couple things surprised me when I look at this data. One is 7% of our community in Stanton and Waynesboro, that's 1 in 14 people, shared that in the past 2 years they had a period of homelessness. That's a very big number. And when we compared it to 2019, right before COVID, to 2022, we've doubled the number of people who shared, I've experienced homelessness in the past 2 years. Well, to set the stage of the impact of homelessness, this study was published last year. I think it's one of the better studies on what's the intersection of health and homelessness. And they took 452 individuals who were over 50 experiencing homelessness, and they followed them for 8 years. And what they found was that 117 of those individuals passed away. That's a lot for an 8-year window of following. But what was very telling from the study is the average life expectancy or median length of life was only 64 years for those who were experiencing homeless over age 50. Where the U.S. life expectancy at the time of the study was 77.3. That's an almost 13-year gap in lifespan. Now in healthcare, I do all kinds of medicines and interventions that might gain 6 months of life, might gain less than that even, some quality of life, but no lifespan gain. This kind of powerful data is why very important for us to be asking about housing security, asking about homelessness, to get a broader understanding of who in our community needs help and what's the kind of help we need. So with that kind of introductory framing, I've got a general question. We are now, as a health system in all of our clinics, asking about housing security. And sometimes we get our healthcare teams and patients who come to us saying, why are you asking this? And sometimes we even know when we're asking, we're not getting great answers. So I'm going to turn to my two experts and ask this question. How do we teach our teams the why we need to ask about it, and how do we ask in a way that builds trust?
It's a very good question. The first thing I would say is you're overthinking it.
Okay. Yeah, probably. Sure.
It really is just as simple as saying, where did you sleep last night? Or where have you slept the most often for the last week? You all are in a really fantastic position because people are choosing to come see you pretty often. Maybe they come in the ambulance, right? But they are expecting medical professionals to ask them very personal questions, like, how much do you drink?
I ask that all the time.
So I think it is just a natural progression to add this question to your list. Sherry, do you have any thoughts?
I think it depends on the situation. Me, myself, I'm very comfortable with my doctor asking me, well, where did you sleep? I think there should be more trust built up between the doctors and their patients.
Thank you.
Good answer. One of the things we've also been trying to train our clinical teams to say, it turns out we ask because we have an answer if you need help. We have really good partners, and who are those partners? What is the type of help? And a lot of my partnership, it turns out, is going to Lydia and say, hey, I need help right now. So let's go on to the next neighbor to share.
Yeah, so our next neighbor I knew for my entire career. He moved in at the end of 2021 and died in the early spring of 2022 at the age of 66. Lived with developmental disability, severe substance use disorder, liver and kidney failure. Had literally homeless with mixed periods of severe housing instability for at least 12 years prior to their move-in in the end of 2021. Had prior involvement with the criminal justice system, but it was little stuff like disorderly conduct and drunk in public and those kinds of things. No family supports, and received minimal SSI, SSDI throughout the time that I knew them.
All right, thanks, Lydia. So one of the themes that neighbor number two, I think is important to lift up is this lack of family support, lack of social support as part of the intersection of health and homelessness. Also, there's a lot of health problems here, multiple chronic health problems, but I'd like to focus a little bit, in this case, on age. This is a chart of everybody that has come to Augusta Health where we were asking about housing status, and either coming to the ER or clinic and told us that they are currently homeless today. And we go back to 2019, and the blue bars are pediatric cases under 17 and under. Then we have in the orange young adults, gray middle-aged adults, orange on the far side elderly, over 65. And what we can see is a real rise in the middle-aged adults. In fact, 2023, this is through August. When we annualize this data, all these bars will be higher than they currently are. And this trend line is a trend line of rising age of individuals who are homelessness locally. Here's another way to look at that. These are people that we've been seeing at the mobile clinic at 4 of our locations where we see more folks who are experiencing homelessness. And these bars are age ranges. So this is the youngest and oldest person we've seen at the Valley Mission in the past year. And we have 21 up to mid-70s. Verona Community Center see a fair number of individuals who are struggling with housing security. You know, they're starting close to 50, and we're getting close to 80 in the mid-upper 70s here. Warm shelter, wide range. Waynesboro YMCA, we're way out here in terms of individuals experiencing homelessness. And where the gray, that's the midpoint of age for this. For the health system working with individuals who are housing insecure, a rising age really heightens that tension between the risks of homelessness and your health status. You are dealing with a lot more chronic health problems. And the way I like to think of it is it really becomes this negative feedback loop that keeps cycling around. And if I am living with if I'm living with COPD and diabetes, and I'm having a bad month, I caught a viral infection, my COPD is acting up, turns out I can't walk as far, I'm short of breath. So I'm having trouble working because I don't feel good. My income goes down. If you have purchased COPD inhalers in the past, some of these are $300 and $400. I might not be able to afford the medicines that would help me get through my COPD exacerbation as well. And I start making trade-off decisions about my rent, my nutrition, my medicines, my utilities. And I reach a point of housing and food insecurity, and that's only going to make my health problems worse. So if I've got my diabetes and I'm on insulin and now I'm homeless, I don't have a fridge to store my insulin. I can't get the resources I need to manage chronic health problems. And you can see how this becomes its recurring cycle. This study, I put the slide in not to go through the details, but I liked what they did in this study. They were asking, does homelessness predict passing away from heart disease? And it does. So if you have an episode of homelessness once in your life, your risk of passing away from heart disease doubles from that variable. So they started to unpack, why is that? And what they were finding is the folks who were homeless and had a higher risk of cardiovascular illness had things we were very familiar with. Their diagnosis was delayed for blood pressure, and their hypertension wasn't well controlled. They had poor control of their diabetes. There was a higher rate of addiction to tobacco going on, higher rates of HIV, and HIV is clearly associated with heart disease, more problems with illegal drug use, which increases cardiovascular mortality. What I like about this is, as a health system, I may say, well, okay, I know homelessness is a risk factor for cardiovascular death, but that's too big. I mean, how do I get my arms around homelessness? That's society. I may realize it's there, but I feel a bit helpless. When I start to unpack it, I find out I'm not helpless at all. Because look at this. I know how to diagnose and control blood pressure. I do it all day long. I know how to diagnose and control diabetes. HIV now, hugely treatable. If I can find out who's got HIV, I can give a long lifespan if I understand where to focus. And it turns out a lot of the focus here in that cardiovascular mortality is things we do. We just need to figure out how to do them in a way that gets access right. So it's getting to the right people. So the questions I have for my colleagues, I just shared some data connecting homelessness to chronic disease. And data is one way to look at what's going on. Lived experience is much better. Sherry's been very kind to share with me in recent months kind of her journey over the past couple years with her health and with homelessness. So I was wondering if you'd be willing to share a little bit with the team about your journey with health and how it relates to housing.
Well, as he said, I stay at the Valley Mission. I'm homeless. I have found out that it's a lot harder to get to and from your doctor's appointments or have a ride to take you to a pharmacy to pick up medication. And if it wasn't for the work that Dr. Merritt and the mobile clinic do, a lot of us at the mission wouldn't get to see a doctor at all. So to me, it's very important, when they come and they diagnose us with something, to stay on top of that.
Yeah, thank you. Any other thoughts, Lydia?
Yeah, so I think it's really important for us to go back to the pie graph that you had, that 55% of how someone's going to, or you know what I'm talking about?
Yes, I do.
That,
All the way back to the social drivers of health.
Yeah.
I'll get there while you're talking.
So, you guys only do 20%, right?
Yes.
I think is what I said. So doctors are only in charge of 20% of health status, or the drivers for health status. Everything else, the social determinants of health, is 55%. And so it's extremely important to remember that, like you said, when you're diabetic and you are experiencing homelessness, you might have a fridge to keep your insulin in. You might also be food insecure, and food is incredibly important to manage diabetes. We've established that. I think it's also important to remember that these chronic health conditions are not things people chose.
Very true.
Right? Like, maybe there were some behaviors that led to them, so we still all deserve to become healthy. It shouldn't matter that our being homeless means that we also then can't be healthy. We also have to realize that housing is healthcare.
Yes. Yes.
I agree with that. All right. Neighbor number 3.
Oh, I got excited. So neighbor number 3 moved in the early 2019 and passed away in the fall of 2021 at the age of 49. They lived with serious mental illness, substance use disorder, and diabetes. This individual had a long-term involvement with the criminal justice system. And y'all, I remember where I was when one of my team called me to tell me that they'd passed away. They had very limited SSI income. This individual was evicted and rehoused. We don't give up on people. They had extremely limited social relationships, which made them become a victim often to scams. So, yeah.
Thank you. And for this case, one, the young age again, very strong, and a number of health problems that are really much harder to manage when you're homeless. And I want to speak to a few of those health problems in a little bit of detail. This is a chart from a study on diabetes outcomes for individuals who are homeless. And you're not going to be able to see the fine print, but we'll send you the slides from back there. But basically, they took folks with diabetes, controlled for all their health problems and age, and then asked, who's coming into the hospital for a heart attack or a stroke? We call those maculovascular complications. And it turns out if you're if you're homeless and have diabetes, you are twice as likely to be admitted for a stroke or a heart attack to the hospital than if you have diabetes and you're not homeless. So clear impact. You're 5 times as likely to be hospitalized for out-of-control diabetes, for ketoacidosis problems. Huge difference. Almost 4 times as likely to be hospitalized for a soft tissue infection, and the rates of lower extremity amputations are almost twice as high if you are experiencing homelessness. One of the things that I think was really valuable from this study, revascularization procedures. This is, I have diabetes and I have a clogged artery, maybe in my heart, maybe in my leg, and I'm running into trouble with that and I get hospitalized. Revascularization means I have a bypass surgery or a stent in an artery to my heart or a bypass to my leg. It turns out that if you're diabetic and homeless in this study, you're less likely to get a revascularization procedure when you're hospitalized than if you're not homeless.
Merritt,
Yes.
you just said that if I have diabetes and I'm experiencing homelessness, that I'm less likely to get a needed procedure.
That is what I said. And I think the next step is to unpack that. So what is really valuable about a study like this, where it lifts up a data point, wait a sec, homeless and diabetes, I'm getting less care, what's going on? And it could be two things. It may be that folks who are homeless are bringing in a more advanced health state, more severe illness, and they're deemed not to do as well if I do an open heart surgery. That may be true, but they don't prove that yet. But it may also be true, and we do see this in some cases where we study an implicit bias in healthcare. It could be that I'm carrying around as a surgeon the idea that a homeless person will not do as well after surgery because there's no family and social support, or some of the other reasons I might say in my mind that it's not going to go as well. And that may not be true. And so what this study shows is a need to go to the next study to understand what's the underlying reasons that folks may be receiving less care on the basis of homeless status. So it's powerful, but it's not understood, and it is unsettling. When healthcare providers see that data and they see a disparity like that, if it's lifted up to them, studies show that it evolves their thinking. They start to realize, wait a sec, maybe I am carrying a bias here. I need to go 2 more levels on this thinking, and you see those gaps closed. So powerful. This is ED visits to Augusta Health in 2022 and 23 for individuals who told us they were currently homeless, and we've had about 700 individuals. What strikes me about that, on top of the sheer number, is that 243 of that column were coming either for a mental health crisis or a drug overdose or drug toxicity. A third of folks coming to the ER who are saying, I'm homeless. That's a powerful number because the baseline is 4% of our ER visits at Augusta Health are for mental health or substance use. So huge difference. And what it tells me is we aren't providing the needed services where they are needed. Coming to the ER for a mental health crisis, you've gotten to the point where this isn't the ideal place to be treating mental health. Getting to the point where you're in a crisis with substance use disorder. So when we plan the services to connect and help individuals who are housing insecure, we need to be thinking about mental health and substance use disorder. If you get admitted to the hospital, this is data from, again, 2022 and 2023 at Augusta Health. And, on the left is the length of stay, 4 days. That's our typical length of stay for everybody that gets admitted to Augusta Health, common length of stay. This is our length of stay for individuals admitted who told us they were homeless. That's a 10-day difference in length of stay. It's a massive difference in how long they're with us in the hospital. And it's really two things, and our teams struggle with this. One, they're coming into the hospital at a more advanced health status where they're bringing that lived experience and risk with them that we talked about. We also know when they're recovering from a pneumonia that they're going to go out in the community without the support that they need to do well. And so sometimes we're also holding them longer, trying to rehab them a bit more, knowing that we're releasing them without a roof over their head or without family support often. This isn't local data, this is national data, but it really struck me, so I threw the slide in. This was a study published in Lancet, which is one of the better journals in medicine, around homeless individuals and traumatic brain injury, and I carry this around as a new data point for me and the teams. In this study, 53% of homeless individuals had some level of traumatic brain injury in their life. It's a massive number. Equally or more profound, a fifth, 22%, had moderate or severe traumatic brain injury. That's a traumatic brain injury level that impacts your ability to process, have memory, problem solve, executive function. There's a lot of disability that comes when you're at the moderate or severe level. As a clinical team trying to work with individuals who are experiencing homelessness, we need to be asking about this. We aren't very structured in this right now because there's a whole set of needs and services that we need to be thinking about for individuals who are homeless who have traumatic brain injury. And then the last thing I want to point out, from a couple of our cases, we've had addiction as part of the health problems that our neighbors are experiencing. And this data is Virginia data going back to 2007. The 3 lines are the number of people in Virginia who died of either a motor vehicle accident, a gun-related injury, or a drug overdose. And if you look at the left half of this, every year in Virginia, about an equal number of people died from each of those 3 causes. And then in 2016, we started seeing what we're seeing around the country. In Virginia, the drug overdose rates, deaths from drug overdose, has really risen. I think of the opioid epidemic as going on for 15 years. It's actually incredibly hyperacute right now in Virginia and in locally. This is ED visits for drug overdose in Virginia and in Stanton, Augusta County and Waynesboro, our primary service area. And the left column is the rate of all substance overdose presentations in Virginia in 2022 last year. So blue is Virginia, green is Stanton, Augusta, Waynesboro. So I just shared the state's rising rapidly, and in this, we are ahead of the state. Stimulant presentations, this is the rate in Virginia. We are twice as much in locally for ED visits for methamphetamine toxicity or overdose. And this is opioid overdose presentations, again, rising rapidly. And then related to this rise in addiction locally is a rise in hepatitis C. The rates are rising across the country. That is tightly connected to the rise in intravenous drug use over the past 10 years. Blue is the rate in Virginia, and then you have Augusta County, Stanton, and Waynesboro, where we are twice the Virginia rate locally. These are new diagnoses of cases of hep C in the given year. I know as a healthcare team, we actually aren't very structured in screening for hep C. It's something we're working on. So I believe once we get better systems in place to actually measure in a systematic way, these numbers will be higher than we expect. So I've shared a lot of things that are give me a lot of pause. I'm sure they give you a lot of pause. The work around addiction in particular, for us, that's an area of growth in our culture of how we provide care. What's our philosophy around addiction management? And we are spending time with our clinical teams around the idea that having an addiction to methamphetamine or to opioids or to alcohol is a chronic health problem that has a lot of cycling. We have good months like diabetes, and we have bad months like diabetes. And when you're having bad months, when you're relapsing, that's when you need to come for us for help. Part of the challenge of managing addiction is the isolation that occurs as part of that disease. There's a lot of shame, there's a lot of impact on families, and people isolate. And you know, one of the messages from this book that I really love is, you know, just don't vanish. That's the message we are giving. We actually know far more how to treat addiction than we did 10 years ago. We have a lot of partners in the community. We need to build our structure for that. So our message is pretty consistently, you know, this is a chronic health condition, and we know how to help. We can help with that. So I've got a book up here. I'm throwing out books because if you're looking for good books around public health issues, this is a great one, Lazy, Crazy, and Disgusting. It's about the biases we carry when we do public health work. And so my question for my colleagues, some of those biases we carry are really health biases. And we cross over into homelessness or housing insecure, and we use language that is health language some of the time. So I'd like to ask your thoughts around biases we carry around homelessness. As a healthcare team, what should we pay attention to? And if you want to speak to substance use disorder, that's a place where we carry a lot of language that needs to be better. So,
I think one of the biases that we carry is we assume that everyone experiencing homelessness has a serious mental illness or a substance use disorder. And that's not always true. We tend to treat homelessness like a character issue. It's not a character issue. We ask people what they did to get themselves in this situation. The real question is, what happened to you? So if we treat housing as healthcare,
Yes.
and we understand that managing our health conditions requires a degree of safety, right? Mm-hmm. It's kind of unreasonable to expect that we're going to expect individuals experiencing homelessness who are in survival mode to then make significant strides towards improving their health. How can they? How can we do that? There are a whole lot of us who live one major event away from severe housing insecurity or homelessness, one very large unexpected Dominion bill, one major car accident, a mistake at work that's irreparable that gets us fired. Sherry, do you have any thoughts that you would like to add?
I think it's important to understand homelessness is something that can happen to anybody out here. You may get up one day and your car breaks down. Well, you can't go to work. If you can't go to work, you're not making any money. If you're not making any money, your bills don't get paid. You lose your house. There you go. You know, so it's important to understand, you know, it could happen to anybody out there. And I think that's something that people don't realize, how simple and easy it is to wake up one day and find yourself without a home, without health care, without the things that you need.
You told us a story the other day about someone you know with substance use disorder, and the things that you shared were profound. Would you be willing to do that again?
Yes, my brother and my nephew both passed away from opioid use. My brother was 46 years old, had his own business. My nephew was a healthy 25-year-old kid. And I think it's important for people to understand that because you have a drug addiction, that does not define who you are. It's just a problem that you have, but it does not by any means define you as a whole person.
Thank you.
I think that's the best message we have today. Thank you. Knowing our time is limited, we have a short last case.
This is a great situation. So this individual moved in 2023, and they're still housed. This person is 57 years old and experienced homelessness for at least 2 years prior to move-in that we are aware of. With this case, we had incredible interagency teamwork between the Street Outreach Program, Augusta Health Mobile Clinic, Augusta Health Community Outreach, Augusta Health Case Management, the community health workers at VDH, the Central Shenandoah Health District, and Rapid Rehousing. This individual does not have income, but it is in process. They have needed a surgical procedure for some years and were unable to receive it without a place to recover. In preparing for the procedure, some additional health concerns were uncovered that are now going to be treated so that the procedure can occur.
Very nice. I want to mention the community outreach team. Most of them are here in the audience. This team has been doing work to expand healthcare access for homeless individuals for 5 years. The amount of individual programs they do and the variety is I love working with the team. It's wonderful. But one of the things they have brought and developed is this honeycomb, if you will, of community partners who we are working with regularly around individuals who need help right now and what's the specific help they need, and how do we get those services. For me, this example and the work we see, it's speaking into this perception that we often carry that this problem is just too large and too complicated to solve. And get local, get with your partners, get into your neighborhoods, engage your teams, and it suddenly becomes more tractable, more approachable, and you realize you have a ton of opportunity. It's I hope we shared some data and examples of why health systems are starting to join summits around homelessness, just tightly connected to making the community healthier. And for me, so excited that we have the number of agencies and leaders and local folks here today is really powerful. We are happy to take questions.
We have time for a couple of questions and then lunch, and I hate to be the guy between lunch and 200 people. So.
Thanks so much. Really appreciate all of your taking the time to share your information with us today. I guess my question is for you, Dr. Merritt. What did it take for Augusta to have this realization and reframe kind of its mission so that it could include this, and are there ways to influence other providers and systems to have that same kind of realization? And then secondly, healthcare providers and their associations are a lot more influential than housing providers and their associations from a political standpoint. How is Augusta leveraging its influence to affect the housing space? And how can we encourage other providers and associations to do the same?
That was a lot. And I wish there were 4 other people who were in the audience from Augusta Health who could join me in the answer to this question. I'll share a little bit. COVID was really clarifying for us. We, as a health system, did a lot of outreach around how do we keep elderly and long-term housing safe during COVID? How do we get PPE? How do we get vaccines? How do we figure all that out? And let's go in the buildings and work on it. How do we get vaccines out to folks who don't normally get to us? We did over 200 unique location events that were vaccine clinics around the community. That was incredible relationship building. It was schools and churches and grocery stores and all kinds of places that we were in where we set up tables and say, we are here to vaccinate, we're here just to answer questions about vaccines. Incredible amount of relationship building. From that, some local councils and coalitions and teams that want to work regularly on local health has grown, and the power of that just has seemed wonderful to us, and we want to keep leaning in. It's not an easy time in healthcare right now. Health systems are in a barely break-even financial state across the country. It is about prioritizing carefully what we focus on. We still believe, though, that this outreach into the community to people who don't get to us still needs to be viable, strong, and moving forward, even while we're struggling on the financial times and having to make trade-off decisions. My CEO, Mary Mannix, would give a much better answer in terms of how to influence other health systems. We are not alone in recognizing the impact of social drivers of health. One of the very promising things for me is that payers for health care are starting to lift their attention in this direction. CMS, our Medicare, Medicaid federal agency, is starting to tie funds flow and quality of care performance metrics to how well you care for those who are more disadvantaged in your community. It's early work, but it's promising. Payers are starting to partner a little bit with health systems to say, hey, there's a housing initiative going on in your community. If you'll do wraparound services from a healthcare, we would love to support that, because the people we're insuring who aren't getting good health care right now, you would extend our reach and actually save us money. And so the conversations are getting more advanced in a good way. It's a long journey for that.
All right, yes, sir. As Avi said, I'm not fast, excuse me.
I was hesitant to stand up, but I wanted to first thank Lydia for inviting us, and Dr. Merritt and Augusta Health. You're absolutely correct. My name is Dr. Wilburn. I manage the balance of state for Virginia. And one of the things that we are seeing at the state level is healthcare providers are coming to us, wanting to join the balance of state because they see the need, and not only that, but they see that there's opportunities to connect. And we just had a healthcare provider that we're going to have join the balance of state because healthcare providers have so much to offer. So whether you're a COC, LPG, whether you're a builder or whoever, I encourage you to reach out to healthcare providers. From a federal standpoint, from the balance of state, we see that the federal government is at some point slowly moving to having healthcare providers come in when they're looking at providing federal funds through DHCD. So I just encourage you and I say thank you so much because I meet once a month with all the balance of state throughout the United States, and we're talking about that, and we're finding that more healthcare providers are joining because there is a need, and you do offer so much. So again, thank you so much today.
Thank you for that very much.
All right. Well, thank you, everyone. We are at time for lunch. So thank you. Let's give our presenters a round of applause. Thank you all.